Abusive Head Trauma and Child Physical Abuse, a program for physicians. Our objectives in this module are to understand the injuries involved in sequela of pediatric abusive head trauma, understand the medical evaluation for suspected physical abuse, including abusive head trauma, and recognize common presenting scenarios of pediatric abusive head trauma and other occult injuries. We'll start just by talking about the evolution of terminology. Many folks have heard several different terms for this phenomenon, abusive head trauma, over the last 15 to 20 years. As it was first described, it was the shaken baby syndrome. We have gone through non-accidental trauma and inflicted neurotrauma. The evolution of terminology has occurred over the last 15 to 20 years. We've heard non-accidental trauma, inflicted head injury, and of course it was first described as shaken baby syndrome. However, since 2009, the preferred terminology is abusive head trauma or abusive head injury. There are a number of different reasons for this. We are trying to move away from the term shaken baby syndrome within the medical legal field for a couple of reasons. First is this type of inflicted injury is not limited to babies. It's seen regularly in children who are even as old as 4 years of age. There have been case reports of children as old as 8 years of age who have died from this form of abuse. We also know from decades of research that often the mechanism of injury for abusive head trauma is not limited to shaking alone. In some, but certainly not all cases, impact and other mechanisms can also be involved. However, one aside is that we do continue to use the term shaken baby syndrome when we're educating the lay public because they understand this term and what it refers to. But in the medical record, we prefer the term abusive head trauma. Here in Kentucky in 2007, we were first in the nation for the child abuse death rate. We average here in Kentucky between 30 and 40 child deaths, and we have another 30 to 60 near fatalities per year. A near fatality is any time a child is in serious or critical condition as a result of their abuse. Abusive head trauma is the most dangerous and deadly form of child physical abuse. And it is very rare for a child to die or be permanently disabled from maltreatment the first time they're abused or neglected. And this is a critical point because what it means is that this is an escalation of violence over time, and that if we can recognize the early warning signs, we can intervene before the children are badly injured. And as physicians, we are in a unique position to recognize and intervene on behalf of these children. So why are doctors so important to this issue? What makes us so unique in this entire process? Well, when physicians suspect abuse, we are immediately in a position to help ensure that the appropriate evaluation is performed right away. We can send them on to the ER, we can order laboratory and radiology studies, whatever is necessary to be sure that the child has the appropriate medical workup. And when physicians suspect abuse, we often have the last opportunity to obtain an unguarded history from caregivers before those caregivers are aware that abuse is being suspected. This is a critical opportunity that, if we recognize it and take advantage of it, can be extremely helpful for investigators and for the courts in their attempts to protect the child. And then finally, when physicians report abuse, our concerns are often weighted much more heavily by investigators due to the credibility that our training brings to the equation. So what exactly is abusive head trauma? Well, it's a global brain injury caused by rotational angular forces. Essentially, as the child's head is whipping back and forth, the brain is being sloshed around inside the skull, and those brain cells are being stretched and distorted and damaged. This type of abuse involves shaking, impact, or both. We can see subdural hematomas, retinal hemorrhage, scalp bruising, skull fracture, but it's the injury to the brain itself that causes the death and disability in these children. The most common trigger is crying, and it is again not typically a one-time event. The brain injury can be evident in a number of different ways, but remember that the brain can be injured in the absence of obvious radiological abnormality. Just think of the concussion that we see in football players and other situations. There are usually no imaging findings there. Brain injury can be evident from clinical symptoms such as altered consciousness, a history of loss of consciousness, apnea, irritability, loss of function, and seizures, among others. It can be evident from increased intracranial pressure-related signs, such as a rapid increase in head circumference that can be detected on an outpatient basis, a bulging fontanelle, splayed sutures, hypertension, bradycardia, and vomiting. So how does shaking cause an injury to a baby? Well, the subdural hematoma is the most commonly associated injury that we see in abusive head trauma, and the subdural hematoma can be detected on a head CT. What we see as the brain is sloshing around violently inside the skull is that the bridging veins here that are draining blood from the brain into the sagittal sinus stretch and tear, and when they do so, they bleed into the subdural space. And this is the subdural hematoma that can be detected on a CT scan or MRI. Now, once a child has a subdural, there are a few different things that can happen subsequently. Most commonly, the body spontaneously reabsorbs that fluid, and the subdural completely goes away. In some situations, the body does not completely reabsorb it. The blood eventually breaks down, and you eventually have a chronic subdural hemorrhage. That too can be detected on CT or MRI. And in some cases, but not most, in abusive head trauma, the subdural can be large enough that it becomes a space-occupying lesion, and in those cases, it needs to be drained surgically. However, the vast majority of subdural hematomas that we see in abusive head trauma are thin, non-space-occupying subdurals smeared over the convexities. Here is another way to look at the subdural hematoma. We have scalp tissue up at the top, the skull bone here, and we have the superior sagittal sinus here. And as the bridging vein is traversing this space, during a shaking event, it breaks and bleeds into the subdural space. And here is a diagram that helps demonstrate the rotational angular acceleration deceleration type of movement that we see in shaking. What doesn't cause abusive head trauma injuries and findings? This is, I think, very important for physicians to understand because these are issues that are often portrayed in the media and in high-profile court cases. We hear this both from alleged perpetrators and most commonly professional defense witnesses and defense attorneys. Often these injuries, particularly subdural hematomas, are blamed upon shortfalls, such as rolling off the couch or rolling off the changing table or just falling from a standing position. We also sometimes hear explanations for the injuries, such as bouncing a child on your knee or vigorous play. These injuries have been alleged to be associated with immunizations, vitamin C or D deficiency, birth trauma, and injuries inflicted by toddlers, pets, and siblings. None of these have any significant scientific basis whatsoever. Shortfalls can cause injury, and they can cause serious injury. However, those injuries look very different than those that we see in abusive head trauma. The case of birth trauma is a special case because a normal vaginal delivery can involve subdural hemorrhage and retinal hemorrhages. However, those tend to resolve within 1 month after birth, and there are several features between the two that make them easily distinguishable when a child abuse pediatrician is evaluating the case. According to the American Academy of Pediatrics, the act of shaking leading to shaken baby syndrome is so violent that individuals observing it would recognize it as dangerous and likely to kill the child. This is a powerful statement that really gives us an accurate sense of how violent this action is, so that we can't be easily swayed by histories that tend to minimize the amount of force that's involved. We often get asked about the question of impact and whether or not impact was involved in a particular child's injury. The truth is that when children survive, we have no way of knowing for certain if an impact occurred or not. Obviously, if we see a skull fracture or a scalp bruise or scalp swelling, then it becomes clear that impact was present. However, impact into soft surfaces can leave no evidence of impact at all, such as into a couch or into a bed. If a child is slammed down, they can have the rapid deceleration that's involved with impact without any external signs of that. Likewise, be aware that the absence of soft tissue swelling over a skull fracture is not sufficient evidence to suggest that the fracture is old. So the take-home message with impact is that the absence of evidence of impact does not mean that impact didn't occur. Other injuries that we can see in other parts of the body aside from the head are metaphyseal fractures, rib fractures, and essentially fractures of any other bone in the body. We can see bruising of the skin, and that can include the torso, the arms, and the legs, and we can see internal abdominal injury. One important thing to understand about internal abdominal injury is that we won't necessarily see bruising or evidence of that injury externally. That is part of the reason that the screening abdominal trauma labs are so important, that we're going to talk about a little later. Or we can see nothing. Sometimes these children present looking pristine on the outside. So when considering the possibility of occult injury, never be falsely reassured by the absence of bruising. It's astounding the severity of injury in children that can remain clinically occult. Metaphyseal fractures are one of the most highly specific types of fractures that we see in inflicted injury. And this is a diagram to remind us of the anatomy of an infant or young child. Essentially, the epiphysis is still cartilaginous. You have the growth plate internal to that, and the zone between the shaft of the bone and the epiphysis is the metaphysis. And during a shearing injury, where the bone has been snatched or grabbed sideways, you have forces that cause disruption across the metaphysis. And on x-ray, you see a thin rim of calcified tissue distal to the fracture site that's often referred to as a corner fracture or a bucket handle fracture. Corner fractures and bucket handle fractures are the exact same injury as a classic metaphyseal lesion. They are just different terms for the same thing. We also commonly see rib fractures in association with abusive head trauma or just child physical abuse in general. The mechanism for rib fractures is anterior-posterior compression or squeezing of the chest, as you can see in this diagram. As the sternum is pressed toward the spine, you get bowing of the ribs at the sides where they can crack, and most commonly posteriorly, right where the rib levers against the transverse process of the spine. The ribs actually crack on the inside surface of the rib, and we can sometimes see this if we do CT scans of the chest. Posterior rib fractures are highly specific for physical abuse. They are not seen with a direct impact to the back. This slide demonstrates the appearance of rib fractures on x-ray. You can see here on the right side of the child's rib cage that the rib edges are nice and smooth. However, when you look over here to the left, you can see these bulbous areas of callus. These are healing rib fractures. These 4 are posterior, these 2 are lateral. It's important to remember that we won't see this evidence of healing for 10 to 14 days. So sometimes when rib fractures are brand new, they are impossible to detect. This is part of the reason that the follow-up skeletal survey is so critical as part of the child abuse evaluation. Bruising is one of the most commonly overlooked early warning signs of physical abuse. If we can learn to recognize bruising and to understand what bruising is normal and what bruising is abnormal, we have taken great strides in our ability to help protect these children. The 10-4 bruising rule was developed at Kosare Children's Hospital in Louisville with U of L faculty members, and it stands for torso, ears, or neck. So any bruising of the torso, ears, or neck in a child 4 years of age or younger, or any bruising anywhere on a child 4 months of age or younger. As you can see in these images, this is an example of torso bruising. You have multiple parallel linear contusions. We also have the very classic vertical gluteal cleft bruising that we see with multiple blows with an open hand or a paddle. Here we have ear bruising in a 7-month-old child who was kicked in the side of the head, and here we have neck and torso bruising in a 4-month-old who is the victim of abusive head trauma. Here are 2 clinical examples of torso bruising. The first image is a 9-month-old girl who was babysat by mom's new boyfriend for the first time overnight, and when mom arrived home the next day, she thought the child was not acting herself. When she went to change her clothes, she saw the single bruise on the child's abdomen. Luckily, that prompted the mom to seek care for the child in the emergency department. Because we had bruising to the abdomen in a child who was not yet mobile, the child underwent a complete evaluation for physical abuse. Her head CT and skeletal survey were normal, as was the rest of her skin exam. However, her trauma labs indicated AST and ALT in the thousands, and that led to an abdominal CT, which revealed a grade 3 liver laceration. This was a child who had a normal abdominal exam to multiple different physicians in the emergency department and was alert and awake and sucking on her pacifier, yet she had a serious life-threatening internal injury. This was evidenced only by a single bruise. The child on the left is a 9-month-old child who was babysat by mother's new boyfriend for the first time overnight. When mother arrived home the next day, she felt the child wasn't acting herself. When she changed her clothes, she noticed the single bruise on the abdomen. Luckily, this mother decided to seek medical attention for the child because she was concerned. Because we had unexplained bruising in a non-mobile child of the torso, this prompted a full evaluation for physical abuse. Her head CT was completely normal, as was her skeletal survey. However, her screening abdominal trauma labs indicated an AST and ALT in the thousands. This prompted an abdominal CT, which revealed a grade 3 liver laceration. In the second scenario, this infant was caught in the middle of a domestic violence dispute and was assaulted in the process. A neighbor who overheard the fight and heard the child screaming called 911. When investigators arrived, the child was bundled and swaddled in a crib and was reported to be napping. However, when investigators looked more closely, they found that the child was actually unconscious. This child, in addition to the visible abdominal and torso bruising you see here, also had a duodenal hematoma, a pancreatic laceration, and a grade 3 liver laceration. These were life-threatening injuries that, had a neighbor not called 911 and had the investigators not done a thorough child welfare exam during their visit, these injuries would have been missed. Here are 2 examples of ear bruising. Ear bruising can come in lots of different shapes and sizes and can involve essentially any part of the ear. But what we know from our research data is that ear bruising is exceedingly rare from normal childhood wear and tear. They are, however, very common in cases of abusive head trauma and other forms of physical abuse. This is an example of a 3-year-old who was picked up and thrown by his ear, so this is an example of a crush injury to the ear. This is a 2-year-old who was in the intensive care unit with a liver laceration and multiple other abusive injuries. This is an example of her ear bruising as well. This image also reminds me to point out that we have to be extra careful when we're examining and evaluating children with darker skin pigmentation, because their bruising can appear just to be red, and that sometimes can be mistaken for inflammation. When trying to distinguish between contusion and inflammation, apply blanching pressure. If the redness blanches with pressure, that's inflammatory redness. That blood is still intravascular. However, if you still see the speckles of redness with the blanching pressure, then you have extravascular blood, and that's indicative of actual injury or contusion. Here we have 2 clinical examples of neck bruising. In this first image, we have multiple bruises along the jawline, the neck, and the chin in this 2-year-old who ultimately died from his abusive head trauma. These types of bruises under the chin and jawline are very ominous and should always be fully evaluated. We do not see bruises in this area in children who have normal childhood accidental injuries. In this picture, we have a 9-month-old child who presented to the pediatrician with complaints of ear pain. Mother was concerned that he had an ear infection. Only when asked about these findings did mother report that he had slept on a Lego the night before, and that was her explanation for these bruises. In reality, once investigators became involved, it became clear that the boyfriend had actually awakened in the middle of the night to the child's crying and had strangled him until he passed out. So these are the bruises that were left behind. As the 10-4 bruising rule, we have torso, ears, and neck in any child younger than 4 years of age. The second part of the rule is any bruising anywhere on a child 4 months of age or younger. These are 2 examples of many that we have seen in our program of infants who present with bruising. In the first image on the left, you have a child who has 2 tiny little bruises just above the pubic bone. When asked about them, the mother reported that she thought that they were from when she buckled him into the car seat, since that is where the car seat buckle seemed to land. In reality, however, this child ended up having multiple fractures and internal abdominal injury. Because of these 2 bruises, his pediatrician sent him directly to the emergency department for a complete evaluation, where the remainder of his injuries were identified and he was able to be protected. The example on the right is a 4-month-old who presented for a 4-month well child evaluation. No social red flags, no concerns with the family, but there was this single bruise on the back of the left thigh. The family was unsure where the bruise came from or when it had first appeared. Because of the 10-4 bruising rule, the doctor decided to send the child for a full evaluation, where he was discovered to have multiple fractures. Remember, when evaluating babies, those who don't cruise rarely bruise. We know that pulling up and cruising is a critical developmental milestone, and until children are doing that developmentally, they are not earning bruises. Some of the common explanations that we hear from caregivers for bruises that are identified in infants are that they slept on a pacifier or that their head dropped on a toy during tummy time. Sometimes the explanation is that the caregiver was holding the child's face in order to perform nasal suction or medication administrations. We sometimes hear that the child's skin was pinched while strapping them into a car seat, or that the child's head was hit on the handle of a car seat or a car door or door frame. Now, this last one is true at times. We all know that that happens, but we've also heard it in our abuse cases. Slap marks are the most common patterned injury that we see in child physical abuse, and while they don't fit into the 10-4 bruising rule necessarily, they are important to recognize. Anytime we see parallel linear contusions, particularly when they're on the buttocks or on the side of a child's face, we need to strongly consider the possibility of slap marks. Linear contusions such as this do not occur from falling against a hard edge, such as a table or stairway treads. If that's the explanation that's being provided, that should be suspect. And then finally, when applying the 10-4 bruising rule, that is helping us understand which bruises are high risk and need further evaluation. It's helpful to know, too, which bruises are normal. Normal accidental bruises in toddlers and older children are typically on the front of the body, and they tend to be over bony prominences. Bony prominences are the areas where we have skin immediately overlying bones, such as the forehead, elbows, knees, and shins. And as you can see in these photographs, you can have multiple shin bruises in an active mobile toddler, and that can be completely normal. Same with forehead bruises indicated here. Again, remember, those who don't cruise rarely bruise, so until a child is developmentally pulling up and taking steps, they should not have bruises of any kind. Now we'll talk some about common presenting scenarios in abusive head trauma. We've already discussed infants with bruises. Other common presenting scenarios are vomiting without diarrhea. This obviously is an indication of increased intracranial pressure, but it can also be an indication of intra-abdominal injury. The apparent life-threatening event, also referred to as the ALTI. Anytime a child has an event that scares the caregiver and makes them think that the child's life is in danger, whether it is that they stopped breathing or appeared to have seizure activity or seemed to be choking or just suddenly became limp. Any of those apparent life-threatening events should have abusive head trauma as part of their differential. And then finally, seizure without fever, especially a first-time seizure, should make us think about the possibility of head trauma or some other pathological process going on inside the head. From an outpatient perspective, abusive head trauma is sometimes detected due to a sudden increase in head circumference that is noticed when the child's growth is plotted on the growth curve. We often see this, unfortunately, in retrospect when children come in with serious head injuries, and in retrospect, looking back in the primary care records, we see that they had a jump of more than 2 major percentiles in their head circumference. If we see this, we should strongly consider head imaging of some sort to identify the underlying cause. Inconsolable crying is a very common presenting symptom of abusive head trauma, as is occult or hidden fracture or an incidental finding. For example, a child comes in for a cough and has a chest x-ray and rib fractures are identified. And then sometimes children who are victims of abusive head trauma don't present until they begin to have delayed milestones and other forms of developmental delay. Other presenting scenarios for abuse include bright red blood from the mouth of an infant. It's important to distinguish this from hematemesis. We also, though, can see torn maxillary, mandibular, or sublingual frenula. Obviously, this is the most common source of the bleeding when we see bright red blood from the mouth, but sometimes children have other sorts of injuries in their mouth or their digestive tract. This can include the soft palate, the tonsillar or pharyngeal lacerations. We even see esophageal perforations in child abuse, and these are well described and can be fatal if left unrecognized. The severity of the symptoms can vary by the severity of the brain injury. Sometimes the symptoms are subtle, such as vomiting and poor feeding, poor focus, or the child isn't tracking objects across the room the way they used to. Sometimes the symptoms are more significant, such as lethargy or difficult to arouse, unusual sleepiness, or just seeming spaced out. Seizures, difficulty breathing, even progressing to apnea, bradycardia, cardiac arrest, and death are all ways that these children do present after their injuries. The medical evaluation for suspected physical abuse involves a head CT. This is looking for subdural bleeding and brain swelling, and of course any other potential cause of the underlying sign or symptom. The skeletal survey and a follow-up skeletal survey in 10 to 14 days. It's important to understand that this is not the same thing as a babygram. The eye exam to look for retinal hemorrhages, trauma and bleeding labs to screen for signs of internal injury or bleeding disorder that could provide an alternative explanation for the findings. We also recommend abdominal CT if the occult abdominal trauma labs are abnormal. MRI of the brain and spinal cord is recommended for all abnormal CTs if abusive head trauma is suspected. MRI can demonstrate subtle brain injury that CT can miss. And of course, we recommend photography of all visible injuries and a report to the Department of Community-Based Services, or CPS, whenever maltreatment is a reasonable concern. Some more detail about the medical evaluation. The head CT is recommended anytime we have signs or symptoms of increased intracranial pressure, bruising in an infant, fracture in a child less than 1 year of age, apparent life-threatening event, or whenever a full evaluation is indicated. The skeletal survey is a well-described series of 21 different images that is performed primarily in children less than 2 years of age with suspected physical abuse. This is done selectively in older children only in special circumstances, such as those children who are nonverbal wheelchair-bound and non-mobile, or have other issues with being able to communicate or move normally. The abdominal CT is recommended anytime the occult abdominal trauma labs, which is AST, ALT, amylase, and lipase, are abnormal, or if we have abdominal bruising or symptoms. It is important to understand that the abdominal CT is far superior to ultrasound in identifying subtle intra-abdominal injuries. More about this in a moment. The eye exam is important to identify retinal hemorrhages, and if they are present, ask ophthalmology to please take photographs if possible. These can be very helpful in the courtroom. Laboratory studies specifically that are requested involve the CBC, PT, PTT, AST, ALT, amylase, lipase, and a bag urinalysis if possible. As long as a child is not unconscious and needs to be catheterized, it's preferable to not have a catheterized urine specimen since blood is what we are screening for. And then photograph all visible injuries as soon as possible. Most of us have been taught to identify clinically significant injuries when they are present. Those injuries for which we can affect the medical outcome by providing some sort of treatment or monitoring. However, in child maltreatment, it is equally as important to identify injuries with forensic significance, even if they aren't clinically significant. This is one of the reasons that the abdominal CT is recommended over the abdominal ultrasound if there are abnormal occult abdominal trauma labs. The ultrasound will most likely pick up clinically significant injuries, but they will miss the more subtle, forensically significant injuries that, while they don't require medical care, can make a huge difference in our ability to protect the child through the court system. The following are some common missteps that we see in the evaluation of suspected child physical abuse. Abnormal head CTs that are not followed by an MRI. No follow-up skeletal survey in 10 to 14 days. Inadequate description or documentation of retinal hemorrhages. In other words, we need to know how many there are, where they are, which layers of the retina they're present in, and how far to the periphery they extend. Occult abdominal trauma labs that are not done, or when they are done and are abnormal, an abdominal CT is not performed. Again, this speaks to the forensically significant injuries. AST elevations as minimal as 80 can sometimes be an indication of liver injury that can be identified on abdominal CT that, while not clinically significant, can make a big difference in protecting the child. And then one of our more common missteps that are seen are ordering the babygram instead of a complete skeletal survey. Here we have a side-by-side comparison of a babygram to a single image from a complete skeletal survey. On the right, you see the babygram image, and it's fuzzy and not nearly as distinct as the image on the left. You can see a cortical abnormality here on the right humerus, but you can't appreciate the degree to which the fracture is present until you look at the image on the left. This is from a complete skeletal survey and shows the angulated, comminuted fracture of the right humerus. Other common missteps include poor quality photographs. We need to see the borders of the injuries. We sometimes hear inexperienced comments about the plausibility of injuries from the history that's provided. In other words, we insert our own ideas about what might have happened in order to make the history seem more believable. And then we still sometimes see physicians attempt to date bruises. In the past, in medical schools, we were taught that the color of bruises can help predict their age. However, research over the past 10 years has clearly disproven this. We should not attempt to date bruises from their color. A word about radiation exposure and cancer risk. This has been a hot topic in the last few years and is worthy of our attention. None of us want to irradiate children more than is absolutely necessary. However, it's important to understand that all of the proposed increased risk is primarily theoretical. The risk of fatality when a child abuse case is missed is 10%. That's not theoretical. That has been demonstrated in multiple studies. This 10% risk of fatality if a child abuse case is missed clearly outweighs the theoretical risk of X-ray, and the consequences of missing that diagnosis can be catastrophic. A few words about reporting. We are all mandated reporters in Kentucky, which means we must report any reasonable suspicion of abuse. There are different levels of certainty, however. For example, if an infant presents with bruising and the CBC indicates that their platelet count is 25, then neither additional workup for abuse nor report to CPS is necessary. The bruising is explained by the thrombocytopenia. If we are in doubt, however, always call in a report. You should not reserve your reports of suspected abuse for only those cases in which you are certain that there is abuse. Outcomes of abusive head trauma. The mortality rate is approximately 20 to 30%. Roughly a third of these children die. Among those who survive, up to 90% are affected in some way. The disabilities can include learning disabilities, emotional behavioral issues, speech and language delays, vision and hearing problems, and hormone and growth problems due to pituitary injuries. If we are in the position to care for a child after they've been a victim of abusive head trauma, one of our most important jobs is to help establish a medical home. This can be a challenge sometimes because children, after discharge from their hospitalization, oftentimes go to a medically fragile foster home and may progress to other foster homes or kinship care. Consequently, the constant moving around can disrupt the establishment of a medical home. Anything we as physicians can do to help alleviate this challenge can be helpful for the child. We need to monitor closely for developmental issues. Refer these children to First Steps, for example. Watch for emotional and behavioral issues, especially attachment problems. This is both due to direct injury to the brain and due to the children's possible memories of what happened to them. Hormone problems need to be watched for, as well as learning disabilities. And one group that often gets left out of this discussion are the older siblings that might have witnessed the violence and may need ongoing therapy or counseling. So as primary care providers, if we are in the position to inquire about the well-being of the siblings, this can sometimes be very helpful. There are a number of different triggering situations for abusive head trauma. A crying baby is by far the most common trigger. We can also, though, see feeding issues or frustration with a child's refusal to take a bottle, toilet training challenges, a child's misbehavior and the subsequent discipline that goes awry, argument and family conflict, or caregiver stressors outside the home. That includes financial concerns, job loss, legal trouble, relationship problems. Among the caregivers, one of the most common characteristics that we see in children who are victims of abusive head trauma is that their caregivers had unrealistic expectations of the child's behavior for their age and developmental ability. Immature parent and poor coping skills, a history of CPS or having had prior children removed from their care, or a caregiver who was abused themselves as a child. Fatality risk factors include substance abuse, domestic violence, criminal history, untreated and undiagnosed mental illness among adult caregivers in the home. There are actually characteristics of the child themselves that can make a child more at risk for being a victim of physical abuse or abusive head trauma. Simply being young, 0 to 3 years of age, is the highest risk age range. Drug-affected infants. These infants are at particularly high risk because they tend to go home with caregivers who are either continuing to use drugs or who are trying to get clean, which is a challenging time for any adult, even without a newborn to care for. Further, drug-affected infants tend to cry a lot, can be very difficult to soothe, and can have problems with bonding and attachment. Children who are born prematurely or who have prolonged NICU stays Also, multiples, twins and triplets, all are at increased risk of child abuse. Infants who have colic, and any infant with a physical or developmental disability. The most common perpetrators of child physical abuse are the father, the mother's boyfriend, and the mother. A study in 2002 indicated that children living in households with one or more male adults that are not related to them are at increased risk for maltreatment, injury, death. Specifically, they're 8 times more likely to die of maltreatment than children in households with 2 biological parents. Risk of maltreatment death was not increased for children living with only 1 biological parent. So this tells us that having unrelated males in the home is a risk factor and is therefore important for us to recognize. Another important thing to understand is that mothers are perpetrators of this form of abuse and should not be assumed to not be suspects when investigators are approaching these cases. Why is it important to us as physicians to understand who the most common perpetrators are? Well, for one, it's really important as a primary care provider to understand who is living in a child's home and to update this information frequently. Whenever possible, if we can include all of the caregivers in our anticipatory guidance and teaching with the family, that also can be helpful. Simply identifying it as a risk and speaking with the caregiver who is present with the child sometimes can be helpful. So let's apply what we've learned so far to a case review. A 4-month-old baby boy presents for a well child exam and is noted to have 2 fingertip-sized bruises on each thigh. The parents explain that they came from diaper changes when the child was squirming. The social history offers no red flags. In fact, the doctor has seen the older sibling for the past 2 years and knows the family. What should this doctor do? Well, unfortunately in this case, this pediatrician didn't understand the significance of bruising in an infant. 1 week later, after that presentation, the patient was brought to the emergency department unresponsive and having seizures. He was found to have bilateral subdural hematomas and 13 broken bones. Most of those were healing already, meaning that they would have been identified had a skeletal survey been performed the week prior. Upon review of his medical records after his presentation to the hospital, we saw that he had just been seen 1 week ago, and that his pediatrician described his family as very nice, no concerns, family was described as appropriate, but he was noted to have 2 fingertip-sized bruises on the back of each thigh. This is a perfect example of a heartbreakingly common scenario where opportunities to intervene on behalf of these children are missed with serious life-threatening consequences. So what are the lessons that we've learned from this case review? Well, bruising in babies is not normal. Maltreatment can and does occur in nice families. This is a very important concept because while even in training such as this one, we spend time talking about risk factors, many families just don't have the risk factors there. We have to understand that the absence of risk factors is not the same as the absence of risk. Consequently, if we see bruising in babies, or if we have an abnormal screen on the 10-4 bruising rule, or any of the other presentations we've talked about so far, these need to be taken seriously and pursued regardless of how quote-unquote nice the family seems. Performing thorough skin exams whenever possible can be very helpful in detecting subtle bruising. We understand that a complete head-to-toe skin exam is not practical in every clinical situation, but whenever possible, this can be helpful. Know the household members and caregivers whenever possible and update that information in the medical record often. Just simply asking, are there any changes in your child's environment, new caregivers, new individuals in or around the home can be helpful. Learn about the HANDS program in your area and refer all eligible families. This is administered most often through the public health departments, but is an excellent program that has evidence-based programs to help decrease the risk of abuse, among other things. Teach parents about safe sleep. particularly regarding the dangers of co-sleeping while under the influence of drugs. This includes legally prescribed drugs or otherwise. Also includes alcohol. Teach the ABCs. Children should sleep alone, on their back, in a crib. Here are some take-home messages from this program. Abusive head trauma is the most dangerous and deadly form of child physical abuse. Experience tells us that we often fail to recognize the early warning signs, and we therefore miss opportunities to intervene and prevent further harm to abused children. The absence of risk factors is not the same as the absence of risk. In other words, child maltreatment can and does occur in quote-unquote nice families. Remember the 10-4 bruising rule. This is a helpful clinical decision tool to help identify bruising that justifies further evaluation. A thorough medical evaluation is crucial in these cases. Know which facilities in your area are equipped to do it. Long-term effects from abusive head trauma can vary from subtle learning and behavioral issues to complete dependence for all care. Education of caregivers regarding techniques for soothing a crying infant and the dangers of shaking can be an effective prevention tool. For assistance in deciding how to handle these cases, including real-time telephone support while patients are still in the office or in the clinical setting, you can contact the Caregiver Charities Division of Pediatric Forensic Medicine at U of L. We are available 24 hours a day, 7 days a week for telephone support. We are most easily reached by calling the Caregiver Children's Hospital operator and ask for the forensic nurse specialist on call. For reporting abuse in Kentucky, the 24-hour statewide hotline for pediatric and adult reporting is 1-877-KENTUCKY-SAFE-1. For non-emergent reports from professionals, you can access the web portal through Kentucky DCBS. The address is here, but it's easier to just search for Kentucky DCBS web portal on your browser. Thank you for your attention. There are additional resources available in the companion documents to this training module, or you can always contact the Caregiver Charities Division of Pediatric Forensic Medicine at U of L for more information.